Good afternoon, everybody. We had a whole day of nice lectures taking us through different planes, anomalies. We will do a little bit of teamwork in reaching the diagnosis on 2 patients using a segmental sequential approach. So, as in any part of medicine, risk categorization is most important. While you see the patient, take a proper history and see to what extent you have to go in that particular patient. So this is the history of the patient, 40 years old, multigravida, IVF pregnancy. She had pre-implantation genetic diagnosis and non-invasive prenatal testing. Both were negative. And for those of you who are not aware of these terminologies, this pre-implantation genetic diagnosis is a test that is done prior to embryo transfer to rule out the most common chromosomal abnormalities. It does not rule out any genetic pathology unless you are looking into that particular genetic pathology. And the non-invasive prenatal testing, especially the basic one, it will look at mainly the common trisomies like 21, 13, and 18, and the sex chromosomes. And she had a nuchal translucency scan done at 12 weeks, and that came as 2.6 millimeter. And the 95th centile for that particular gestation was 2.3, so this was a borderline nuchal translucency. So she is presenting at 21 weeks for the anatomy scan. Any comments? So what are the risk factors that we are seeing in her that increases the risk of cardiac abnormality? IVF and borderline nuchal translucency. Bravo. The information all set in. Dr. Suleiman, Mabruk at the end of the Congress. Okay. Here is the situs. So the most important, as Dr. Diana was mentioning, you can see, this is, I like the term Dr. Suleiman, he mentioned, the spine is the center, the heart. This is very important for us to understand. There is one trick I can tell you, that this situs is normal if the baby is in cephalic presentation. And it will become situs inversus if the baby is in breech presentation. The clue is, if you are looking at the spine and the stomach, it will be in the clockwise direction. Wherever, if the head is here and if the spine is here, it should be in the clockwise direction if it is cephalic, and it will be anti-clockwise direction if it's breech. So what I do normally when I put the situs image, I put the abdominal circumference and the 4-chamber view. Now this baby was in a breech presentation, and you can see the spine and the stomach, it is in the anti-clockwise direction. So this is a normal situs solitus. And look at the 4-chamber view. Any comment? Normal, abnormal? What is abnormal in that? Hypoplast. That's a good thing. Thank you so much for saying that. Actually, I put it mainly for the pulmonary arteries, veins. You can see the pulmonary veins that are connected to the, and it's also present in the collar. So you can say that it is a little bit prominent, but this is very important. This tip actually I learned from Dr. Suleiman when we were doing fetal echo together in Tawam Hospital, how important it is to, and again it was mentioned by Dr. Diana today, we have to put the pulmonary vein in both 2D as well as color. And Dr. Suleiman, he will be even more strict with me, put the pulse wave to show that it's really vein and not the artery. Isn't it, Dr. Suleiman? Okay, now as Dr. Faiza, she's asking, that's the inflow that is showing us red and the blue. That's the 4-chamber. Now can we comment if it is normal or abnormal? This is one rib only. More or less, it is normal, we could call, yani. Any comment? Dr. Diana? It looks relatively normal, yeah? On the right side, yeah? On the left side, okay. Actually, that's exactly correct. Even in the previous image, when I put the first image, I was thinking, why is this right ventricle looks like this left ventricle? It looks a little bit of weird. That's what will happen with most of the cardiac abnormalities. From the beginning, there will be something that is striking you that this is not the routine section that you are used to. This is the most important. Once you have that thing in your mind that there is something not normal, please continue to look at the thing again and again and again and again until you prove either or the other scenario. Okay, and moving on further, yes. Now you can see here, this four chamber, what is showing there? BSD, that's the VSD with still at the, as we sweep up. And here, what you are seeing, as we sweep up, overriding, absolutely. So it's really nice that you got the information nicely. So it is an overriding, and once it is overriding, normally we think it is an aorta, isn't it? So what are the multitude of possibilities once there is an overriding? It could be tetralogy, it could be DORV, it could be truncus. It all depends on where the pulmonary artery is coming from. That's the next clue. So this is the sequential steps that we are doing, yeah? So we are applying color through that valve. There is a significant regurgitation. And again, you can see here, the thing here, that vessel that is overriding, it is seeming to giving rise to branches immediately, which wouldn't be the case if it is a pure aorta. It will give rise to branches little bit away. So what could be the other possibility? A vessel that is situated exactly on top of the ventricular septum in the center and giving rise to vessels. Truncus, absolutely. So right now, we are most probably dealing with truncus. Yes, you can see two valves. And it is a little bit of dysplastic. Exactly, points taken. So now you are orienting your mind to, okay, most probably it is a truncus. And the next thing is what kind of truncus? It could be what type. There are Colley and Edward and Van Prague, two classifications are there. In either way, you need to, prenatally, it is so hard to see the pulmonary artery. And we have worked a lot with Suleiman and Dr. Hamdan. We have seen so many cases of truncus, but this is the first patient in which I could see pulmonary artery properly, and that's the reason I was so excited about this case. So you can see again here, that's a huge vessel, and you can see another vessel coming from here, just at the posterior. So, and again, if you are looking at the parasagittal view, you can see the vessel that is coming from posterior. So you have a major trunk and there is a pulmonary artery coming from it, it becomes like type 1. I will show you the picture for the different classification for us to understand. But how can we know it is a pulmonary artery is only if I prove that it has branches. So what we are doing, you can see the beautiful branches of the other vessel coming. Okay, it's not moving. Yeah, it's moving. You can see the branches here. Nice two here. So there is another trick to know the diagnosis, going further to the aortic arches. So when there is a single trunk, obviously there will be only one arch. There will not be two aortic arch and ductal arch, isn't it? This is another clue So here you can see that's a huge vessel. It's a single arch here. So we are almost certain that this is a diagnosis, but obviously, you know, this should be confirmed by postnatal cardiology. And this is a different classification of the truncus arteriosus. As we thought it's a type 1, we can see the major trunk with the vessels directly coming from up with the main pulmonary artery that is arising differently. This is the pathophysiology behind this truncus arteriosus is the partial absence of aortopulmonary infundibulum. The aortopulmonary infundibulum will still be there, and therefore you will see a separate pulmonary artery before the division into 2 pulmonary arteries. This classification is very important for the postnatal surgical management. This type 1, since it has a good size pulmonary artery nicely, it has a very good prognosis, and it is easy for the surgeons to operate on it. That's a very good teamwork. Thank you so much. We did very well, I think, in the first case, right? Okay. So the other thing, what is very important, as we were listening to the lectures in the morning, 22q11.2 deletion is the thing that DiGeorge syndrome is very commonly associated with truncus. Prenatally, we have the ability to see the thymus at the level of the 3-vessel view. This is a beautiful publication from Professor Rabichawi, where Dr. Suleiman and the rest of the people in the morning, they showed that this is the union of ductal and the aortic arch into a V sign, and the thymus will be sitting just at the anterior part, like a little bit different echogenicity will be there. And what we are doing, this measurement, it is very constant throughout the pregnancy. If you are measuring the thymus length and divided by thymus-thoracic ratio, this is 0.44 throughout the gestation, plus or minus 2 standard deviation. This was measured in our fetus. You could see this is the 3-vessel view, and this is the thymus is 1.37, and the thoracic ratio is 2.6, so it was about 0.49, which is within normal limits. So most probably, this baby doesn't have DiGeorge syndrome, yes, please, Dr. Suleiman.
I want to check.
Yeah. Yeah, Dr. Suleiman.
Almost convinced me.
Yeah.
You almost convinced me there is another vessel more anterior.
More anterior.
Separate.
Really, Dr. Suleiman, this work I did with Professor Siham, actually. I was telling her I'm always, always seeing another vessel.
Okay.
Yes, this is number 1.
Yeah.
That's the reason someone was asking how much time do we take for this. This patient took 2 times time 3 days.
Okay.
2 hours on 3 different days. But this is the last day that we really got convinced when this vessel was branching.
I wanna add something. It will be a big difference in the management post if it is a truncus type 1 or it is a tetralogy of Fallot, depending on the PDA. Mostly the truncal valve is not normal. You will find the leakage in the valve itself. And we need to see the arch very well, because if there is a vertical duct, because it will depend on the management, it affect the management after, to start Proston or not. If you go back to the colored one, maybe if you slow it to 1 by 1, maybe you will concentrate on the valve itself.
There is a regurgitation in the valve.
Most of the truncal valve, there is a leak or regurg, as you said, will not be normally closure, okay? And we'll concentrate after that on the arch if there is a vertical duct or not.
So this patient is delivered already, I assume?
Pardon?
Delivered or not yet?
No, she's 21 weeks. This week we scanned her.
Okay.
So it's still a puzzle. Actually,
because one of the pictures you show me, almost you convince me.
You know, my other
you convince me that there is anterior artery, which is seems to be an aorta, and this seems to be, splitting.
Pulmonary.
What do you think, Dr. Diana?
I already spoke to, that's the reason I took your opinion before coming. My other imagination is, this is being
What do you think,
a double outlet right ventricle with the subpulmonic VSD, a thoracic being anomaly, transposition, and the other vessel being small because aortic atresia. So this is super imagination, I believe. But
So I probably will go with that.
The second
When?
one?
Yeah. What do you think, Dr. Diana?
Yes,
Did you review?
We were looking the images before. I think it's from this view with that small and the valve. It looks
because
more
we
like
have
that.
completely two separate valves.
Yeah.
But the other one doesn't
in
have
a-
a clear
Yes,
valve,
yes.
Dr. Suleiman.
Yeah.
I can't reproduce it. You have taught me that I should reproduce if it is really there. That I couldn't reproduce.
Yes, yes.
So I
This
have
is
to go
the-
with...
Yeah, this is the beauty about fetal cardiology, to be honest with you. I can make any picture look abnormal,
Yes,
and I can make anyone look normal.
absolutely.
I can make fourth chamber look hypoplastic, and I can make hypoplastic look like a normal
Absolutely.
things with a little modification and playing with the how I am gonna cut.
But Dr. Suleiman, in this picture, the last one, you could see here,
Yeah.
that vessel is really dividing into the other. That makes...
Yeah.
I wish. And that valve, I could not, if there was a valve for the small vessel that is coming from anterior, then it will fit into the, actually on 3 days we reached, the first 2 days I saw her alone, and the third day I saw with Siham. First day I was thinking truncus like this. And the second day, no, there is a vessel coming anteriorly. It should be this subpulmonic or thoracic, but it's too much of an imagination, I believe.
Yes.
The branch pulmonary arteries and then see where the originating from.
That can be more said than done, I believe. Many things you can say, but how much it is practical in real life, really God knows. So I will put both as a differential diagnosis, isn't it, Dr. Suleiman? So we have a debate, Jan. Yes.
Now, since we cannot be 100% sure, no, I mean, I think my voice is fine. Since we cannot be sure whether we have 5 or 6 or 7 fetal medicine people, so what the management postnatal would be the same,
Yeah.
I think.
No.
No,
Just a second, because
Dr. Diana can say I don't know much about
the
it.
development of the arch, any part of the arch can contract at any time. Because this is the nature of the arch. This is how the arch develops. The arch and the major vessels. Any vessels can contract and disappears. So any part of the arch development can contract. So then the management here will be the same if we have multiple vessels coming and we don't know which one go where. So any vessels, when we have these problems, any vessels can contract. This is the nature of the development of the arch.
I
And the
think
major vessels.
the ductal tissue it will contract. If we don't
But the
have
other
ductal tissue,
Just a
it will
second.
contract
If
also?
we go at the beginning of the development of the arch,
Yeah.
because the arch will be multiple blood vessels, like,
Yeah.
like a palm tree,
Mm.
like a palm tree, and when this contract, then the other vessels remains. And when, for example, the latest part of the right arch contract, then the left arch develops. And if we have the left part of the heart contract, then they become the right arch. Because this is the development of the arch. Then any of these vessels can contract because this is abnormal development of the arch. So the management possibly, this is require prostaglandin or just watch the baby all the time because any blood vessels can contract.
I think, this is a little bit beyond what we are trying to establish. Now we are trying to establish, I'm not talking about management, we're talking about establishing a diagnosis, okay? So, and how difficult it is to establish a diagnosis. We're not talking about the outcome or the consequences later.
Even if we sit 6 people, sometimes we are not going to say which one going.
Yeah, can you hold this? Can you hold a second? This is a very beautiful picture. Can you go back to that one? Yeah, this one. Okay, beautiful. Okay, you see one in a different plane.
I agree. Dr.
Oh,
Sulaiman.
beautiful. I mean, I will say this
there
is.
a vessel that is coming from anterior.
Yeah.
But then you could also
Let me-
argue the main trunk, it is giving rise to more than 2
Yeah, can I-
branches. So
can I
in
tell you how-
pulmonary, there should be only 2, I believe. So that's another point here.
Can I tell you how I will read it?
Yeah.
I probably will say this is a little, because usually with truncus, usually the 2 ventricles are normal in size. One of them is bigger than the other. That's a usual, typical picture.
Yeah.
If you look at this ventricle, you will see the right ventricle a
ventricle
little
being
bit in the
little
smallish,
small, yeah.
if you agree with me,
Yeah.
and the left ventricle in the normal or bigger than normal. And there is outflow going, or VSD, you can call it whatever, and there is the outflow of the major artery, the other major artery coming only solely from the right ventricle. The first one probably overriding and so on. So this is will still in my mind, right ventricle hypoblast variance with, double outlet, or if you want, or you can say overriding pulmonary, and the aorta is far more anterior. That's how I see it.
Yeah.
And definitely this patient with a small arch, probably if you can show the arch with it, probably you can decide if you need a prostaglandin later on or not.
Yeah. But probably we can continue to
Dr.
scan
Diana,
her-
please correct me if you don't agree. Feel free.
Yeah.
I think now looking at this image here, I agree with you. There is this, looks like this
More anteriorly, there is another one. Yeah. Yeah. I couldn't, I will call her again and I'll try to see if there is a valve.
No, you bring her and we scan together for 3 days.
Okay, we'll do that.
Yes, we can.
We can.
Yes, we can.
Actually, doctor, we don't see this long duct. This cannot be.
We are trying to establish a diagnosis only. This one for me, from the medical point of view, from the scanning point of view, okay, not from the embryology development. This for me, so far, look, hypoplastic right, aorta coming out from the right ventricle, and the pulmonary probably have
Subpulmonic
some
VSD,
form.
yeah.
There is subpulmonic VSD. You can say overriding all, but it seems less than 50%. Seems like the pulmonary artery on the top,
Yeah.
directly on the top, like overriding what you see in the tetralogy.
Yeah.
But it's a form of double outlet with transposition.
Yeah. So the thoracic Bing with aortic atresia, because the aorta is being small.
Sinus
So I
is
will
not
put it as a
atresia.
differential diagnosis, and then we will have a look. Thank you for, you see, that's the reason there was no discussion. If I had worked with Sulaiman, we would have agreed on the day 2, day 3, we wouldn't have gone. But with my pediatric cardiologist, I had to go to the day 3 and go back to the truncus, so we'll see. Okay, that's a good discussion. Thank you for all input. Okay. So this is an important point, the thymus, to look at the thymus. Again, what we practice in regular scanning, it will only become like a part of the practice. So we will look at the thymus all the time at the 3-vessel view, 3-vessel trachea view, to make our eyes used to how thymus looks. So in order to pick those DiGeorge syndrome. So the next scan, the patient, it's a completely low-risk pregnancy, routine mid-trimester anatomy. And again, I will leave it to your imagination. That's the situs that we are trying to establish, abdominal situs. The stomach is in the normal orientation. This baby was encephalic, and you can see the clockwise orientation. What else is there is something abnormal. I can give a clue, and it was already shown by Dr. Diana in the morning. What is that? Bravo. So this is the most important thing. So what the whole day we have been saying about aorta, the heart of our spine friend is there, and aorta is just at the front, and the IVC is missing, which is supposed to be right and lateral within the liver. So when the IVC is missing, invariably we will look at another vessel which is on the left side, which is the azygos vein. I will show you the images again. And again, in the four-chamber view, normally we see only one vessel, whereas if there is an IVC, it will go and get connected to the right atrium below the diaphragm. Whereas if it is azygos, it has to ascend through the diaphragm to meet with the superior vena cava. That's how it drains. So you will have two vessels in the four chambers.
Can I comment a little bit?
Yes, please.
Yes. Just to make it more interacting with all of us. When I see this view, again, what's the problem with it? Number one, we have to make it live.
Yeah.
That's number one. So we have to make it live. Now, when you make it live, what you said is absolutely true. But how can I convince the rest of the population around me this is true?
Yeah, Dr. Suleiman, the images were deleted from the machine before I could retrieve.
No.
And then I got it from PACS, and there are no live images.
Yeah. So this is very important.
Yeah.
What you said is very important. But how can I tell myself when I see these vessels? I don't know which one is the aorta, which one is the IVC or the azygos. I don't know. I just don't know. So the first thing you do is you put color on it. Okay. And color with two options: one of the high Nyquist limit and one with the lowest Nyquist limit. Why? Because high Nyquist limit will show me the arteries, and lower Nyquist limit will show me the vein.
And the pulse
and if
wave on top of it.
There you go. You know.
I know the package.
So yeah, and then you can be confident this is artery, this is vein, and this is what I am dealing with. Is that okay with you? I'm sorry? Azygos, you mean? Esophagus.
Esophagus usually we see in the three-vessel view. In the three-vessel view, usually.
What she mean? You see a circle.
Yes.
You see a circle. You don't know what it is.
Exactly.
It could be
That's
anything.
True. Unfortunately, I did all the package what Suleiman is saying. That's the reason. The point what I'm bringing here. Sometimes you will see only one venous abnormality with the rest of the heart being. Let me go through so we can understand that. So aorta and the RVOT both were normal. And again, with the live images, it will be very nice. What we can see in the three-vessel view, you have the pulmonary artery, aorta, and SVC. And that vessel was coming, and in live, it was really showing nicely. And azygos that you could come and join the SVC. And again, that's the parasternal view. You can see the azygos coming and joining the SVC. So other than that, we couldn't see much in this baby. And again, I did exactly the same thing what Suleiman was saying. Like, you have two vessels. Actually, only one vessel will be ascending up, which is the aorta, because the IVC will already enter the right atrium below the diaphragm. But here what's happening, this is the parasternal view that we have right atrium where the SVC is joining, and here there is no inferior vena cava. So this is an isolated interrupted IVC, which is sometimes known to happen. And these conditions, if we don't diagnose, there is no reason we should diagnose this. If it is not diagnosed, it's not going to harm anyone. Unless the baby becomes very big and it needs some procedure related to inferior vena cava, like IVC filter or whatever. I read a case report where it was diagnosed in 60 years old male that they were trying to do a procedure through femoral catheterization. They couldn't reach the inferior vena cava, only to know that the inferior vena cava was not there. Then they had to go for transjugular approach. So these surprises we will get in the postnatal setting. Other than that, it's not going. And one more thing, as Dr. Lian was saying, most of the times when I see some kind of embryological changes, we need to understand the baby is evolving. I had a patient who had persistent superior vena cava, which is completely a normal variant and will not do anything, but then the baby had imperforate anus, which is very difficult for us to diagnose. So you can prepare the patient that there is something embryologically abnormal, and therefore other embryological structures that are supposed to be open, closed, will not happen, or will be there with, and the baby will need full detailed examination in the postnatal setting. That's the lesson. Thank you so much for your attention. So that's the message. Segmental approach is the key, and the teamwork. I wish I will take all of these people when I do the next echocardiography. Thank you.
Thank you very much. It was very, very interesting cases. By the way, I just want to mention, when we do fetal anomaly scan, we don't really analyze what I'm gonna do with this information. Now, I am seeing it's just like a Google map. Google map should take me to show me the neighborhood, where is the street, where I may not pass by that street. I may not need to worry about the IVC or the SVC or whatever anatomy I may see. I may not do any intervention for it. But it's very important when I assume I am doing this and I am to make my work complete. So I may not have a problem with the right atrium, but I have to say the right atrium taking a good size, and it's normal. Left atrium ventricle is like that, right ventricle, left ventricle, and so on. So we have to elaborate in everything that we are saying and make our report as according to that anatomy scan, or we call it anomaly scan, right? Okay, so Dr. Diana, do you have any cases that you want to mention? Do you have any of your collection? Please, please. I would love that. Thank you.
And it should be there. It should be in there. But I only have one sweep.
Actually, it may be a little challenging for us to look.
This one I put at the end.
Dr. Nermin, do you have any cases that in your hand? And the WhatsApp, amazing. While we are looking at this, I just want to, for those people who are interested, we are working with Dr. Iram and Dr. Muzib to have hands-on for these people who are interested to develop some skills on fetal cardiology specifically. So we are planning to have hands-on. I don't know if it will materialize or not. It will cost each one participant about 1,000 dirham, and it will have, we'll have to have probably around 10 to proceed. We have already the machines, and we have the technique, and we have Dr. Nawal Al-Kaabi, Nawal Al-Hubayshi. I'm sorry. Dr. Nawal Al-Hubayshi, she promised she will bring 50 patients. 50, yes. We'll scan them the whole year before they get pregnant until they deliver. So we are working in that, and we are hoping if any of you interested, we'll announce it also to other people. If any of you are interested, we can plan either the next Friday, we'll do it at KidsHeart Center, And we will have probably 3 people scanning and 2 or 3 people with the people who's scanning. Too soon? خلاص بعدها الفرايداي اللي بعدها. Huh? Simulator, unfortunately, we don't have. Yeah, the simulator is a good step. It's a good step between. Let me know when you are ready. Yeah, you can proceed.
Okay, so this one, I have this clip, but it's a sweep, so we should be able to get a lot of information. So the fetal, so the baby, that's the left of the baby. Now, so first thing, if you look at the first, at the fourth chamber at the beginning, stop there. Let me try to freeze it there, okay? So you can see the heart is more on to the right, isn't it? And then when we look at the fourth chamber view, this side, this ventricle, is the one with the moderator band. So this one is smooth, this one has a moderator band. So we have on the left side, the right ventricle, and on the right side, the morphological left ventricle. Yeah, I will run it so Dr. Suleiman can agree. Okay, and then we have this big defect, kind of an inlet ventricular septal defect. Okay, so that's from our fourth chamber. Now we're sweeping up. I can run again. And then the first vessel appears. Yeah, so there's this vessel that is not branching, all towards the left. Yeah. So at the moment we think it's likely to be. Sorry. Yeah. So not branching, and then we have. Okay, so we have the vessel, so we have and then we have this small vessel on the right side. But when you look at it, here it's branching. I'll freeze it so. But they both seem to, if I'm honest, to be committed to that right ventricle that is on the left side. Yeah, so one vessel coming from this right ventricle, and then the second vessel is also coming from the right ventricle. Yeah, we all agree? And then we see the second vessel is smaller, and it's branched. Yeah? So that's probably our pulmonary artery, and it's the one that is overriding the septum. So we have kind of a TGA. This is another possible Taussig vein. So TGA. Here. No, it is here. With a hypoplastic pulmonary artery. So I don't have the color flow, but when we put color, there was a reverse flow, they talked. So this baby was born, and this is confirmed, had a kind of dog-dependent lesion, and now has a PDA stent. Mm-hmm. Yeah, I don't know. Well, I have to say, I do optimize as much as possible.
Yeah, it's very, it's.
I was going to say, this was a late scan. Yeah.
Let me just comment on one thing when we sweep. It's very important for us to know when we sweep what to expect. So the structure of the heart, if you remember what I showed you in the morning, I say this is what we expect. So behind my hands, I should have, I'm sorry, just I will comment so I can.
Yes, I'm going to try to
I should have the right ventricle and left ventricle. The right ventricle always anterior, remember that. We call it right ventricle, we are lying to you about that, but it's right and anterior. The reality, it's more anterior than being right. And then the left ventricle is posterior and being left. So when I am sweeping, the first, if I am seeing both AV valve in the back, that means I am in the back, right? If I see the AV valve, that means I am more posterior, correct or I'm wrong? They cannot be in the anterior portion, and the aorta doesn't work like that. They have to be both of them anterior. So when I sweep in normal situation, knowing nothing about anatomy, what should I see first? Look at my hand. What should I see first? I see both AV valve in the back, and I sweep anterior. What should I see? The aorta. Case closed. case closed. If I don't see the aorta first and I see an artery that kind of branching, that is transposition until proven otherwise, of some form. And this is what's going on with this patient, the one that you were talking about.
This is a normal sweep, just for
Yeah,
you to...
yeah. It's an excellent. So you see the aorta, when you sweep, you see the aorta and you see the pulmonary. The pulmonary gets right under the sternum, right away. It's not far at all. So this is the normal sweep, but if you go back to the one that you showed us, you will see the pulmonary. Look at it. It's very beautiful. You showed it very nice. You see that? You see? Okay, I am sweeping. She got the big fissure right there in the front. And later on, she saw the aorta. Later on, not in the beginning. So she saw first the big fissure, more anterior, and she saw the one after that. I should see the aorta first, if it is a normal relation. So probably if you manipulate a little bit, you will see both of them at the same level, but we are probably angling in some format. So we are not seeing them together at the same level. So the first one to see the pulmonary artery branching nicely, that's a transposition until proven otherwise, a form of transposition. Yeah. And this is probably a form of double outlet right ventricle. Yeah, with small arch.
And with exactly.
Yeah. We need to clarify that more. Tosic being, when we say it, it's a big spectrum by itself. The most important portion of it, it's the worst VSD you could have. It's bad VSD. That's number one. So even if the aorta is good, you're gonna go for a heart failure. If the aorta is small, you're even gonna get worse and you will need to do something in the near future. So it's a massive ventricle septal defect when you say Tosic being. Yeah, sure. Okay. Just let her.
Yes, it does. That one, I had to use it also for my so it has left isomerism. Let me go back to the, so in this one, when you look at so there is, as the azygos is behind similar to the one you showed, the azygos is behind the aorta. Here I don't have, but so the vessel, there is the aorta, and the one behind is the azygos. And when if I show you, because I know it's, and I know from because I use it for when I was explaining the left isomerism. So if I go back to my isomerism, sorry, it's not very, here. So this one. So this is the same patient. And you can see when you follow both vessels, how they start going, to how you have this aorta, and behind you have the azygos. And I don't have my computer, but I have it in color, showing similar to what you showed, so it's the same image.
Just to comment on the azygos, you very, very frequently will see the azygos, very frequently. The problem is that you're going to see it very small. Why? Because most of the blood will go. And when we scan the patient after birth, we see the azygos, which basically join usually the SVC near the entrance of the right atrium. So that's when we want to follow it. And almost it's not difficult for us to identify it, especially with patient with ASD, where we get confused. What is this thing that coming right there? And that's usually the azygos. But usually it's small and not an important thing.
This is one of our cases in Dubai Hospital, our team there. A case from departmental found there is anomaly in the heart, but they didn't differentiate with it. If you go back a little bit, this valve, only one AV valve coming, but there is a severe rigor. Can we start again? Malalignment VSD was overriding of one vessel. I couldn't see the other. And there is a regurg in this valve. We'll continue sweeping. I didn't see the pulmonary at that time. Then more sweeping will come in. from the posterior part of the branching pulmonary. This was a case of truncus. Actually, it was type 1A, and that time delivered in Latifa and sent in Jimi. I will keep it for more sweeping if you want to comment on it. This is the arch and the pulmonary.
I think you showed the anatomy for me reasonably good. Yeah, I saw both pulmonary arteries rising from the main trunk in both position. And then I saw the arch also giving the branches to the rest of the... so usually in the true truncus, usually you don't have a PDA in a real truncus in life. So you don't have a PDA. That's the one that coming after the valve, you know, the blue color, that's an extension of the pulmonary arteries from there. But I think this is a very clear for me to call it truncus. What do you think, Dr. Diana?
Yeah, I think I agree with you. I think it looks...
And what a beautiful pulmonary veins that you showed. Very nice, that entering the left atrium. I think you can...
There you can see.
So this is the single, yeah. So this is the single, I'm getting lost.
Yeah.
What is this? There. So you see the branching coming out of for the head vessels, and usually that doesn't go with a duct. You're assuming this may be duct, whatever. I mean, this, I have a single trunk coming out, and that's maybe, you know, maybe branching, maybe not branching, and maybe this is duct, maybe not duct. When you see a vessel that making branch, that's an arch until, not a ductal arch, that's an actual arch until somebody tell you the medicine have gone back to 300 years back. But because the PDA will never give you branches for your head and will not give you, only will serve you for your pulmonary arteries. It will not go away. So you may miss the PDA, but you never, ever miss an arch. It could be small arch. It could be disrupted arch, interrupted arch. It could be anything, but you cannot say there is no arch. There is no such thing. Name is there is no arch or whatever vessels there. So the arch is a very important comment. Now the pulmonary artery different. The pulmonary artery different. You may miss the whole total spectrum of the pulmonary artery. You don't see a pulmonary at all. And that's the worst type of what? Worst type of what? Tetralogy of Fallot. So that's the worst type of tetralogy of Fallot, where you only see the aorta, you see the branches going to your head, so you are alive, but you don't see anything else. You don't see a PDA. You have nothing in your hand. You can't tell. So where is the patient? How is he going to feed his lung? He has to stay alive after birth, and that patient must have what we call it MABCAS. What is MABCAS stand for? MashaAllah, MashaAllah. It seems like we have. Okay. What? Man? Okay. So major pulmonary artery collaterals. Okay. So this is a very important concept. You never lose the arch. No matter what, you have to see it. You have to identify it. You have to feel comfortable with it. But you can lose the pulmonary arteries. Same thing, to be honest with you, even with the fourth chamber. When I lose, I don't see the right ventricle and I feel bad, but I consult the patient different. If the right ventricle is not there, the outcome is much better down the road, because the left ventricle will serve you for a long period of time. Do you want me to give you just a raw pictures for you to comment on it? You have one? Please. I asked you, you said you don't have. عندنا مثل يقول لك بيت الأسد لا يخلو من العظام. ف don't worry about it.
Not there. You're right.
Don't worry, she doesn't bite. Can you just tell us what are you Doppler just for where is your line? Where are you Dopplering?
This was not an M-mode, it's just the umbilical.
Yeah. So this is the umbilical artery and vein. I assume this is the umbilical artery and vein. So you are just Dopplering to see what's going on. Okay.
Yeah, I could not do an M-mode. How many weeks?
21. Any guesses? Because I'm trying to get the atrial and the ventricular contraction rates, which I cannot do in the M mode. So the only other way I can see if the atrial and the ventricular beating rate is different is by trying to put the two waves together. Yes. Correct. Yeah, so this is a 2:1 heart block, second degree heart block. But as I said, the M mode was tricky, and not every time you can get a nice M mode. So this is the other way of checking your atrial and ventricular rates. So this patient will, I did the anti-SSA and SSB antibodies. She does not have any history of SLE, any rheumatological conditions. She has 3 normal children. Both the antibodies came back negative. But we want to know from the cardiologist what is the prognosis for this baby.
So I will just ask a question. What do you think about, other than the difference in the rate, what about the atrial pulsation and the venous pulsation? Are you okay, Dr. Diana, with that?
Do you mean with the pattern, with the frequency?
Yes, the pattern.
Yeah. Thank you.
Correct. So this is a very, very important signal. As a matter of fact, when you see this, when you see the umbilical vein is not straight line because there is really no pressure pulsation in it. It's supposed to be smooth blood going from the maternal placenta area to the baby heart. It should be smooth without any pressure. If you see it pulsating like this is one of the how many of you familiar with cardiovascular profile? What are we looking at in cardiovascular profile? That's how we, as a cardiologist, how we evaluate the heart, and we say the heart is doing good or the baby can survive. Don't worry about it, Dr. Muzib. The patient can, and we grade it from 1 to 10. So we look at this. Will give you 1 point, not 2 points. Actually -1 because you don't. If it go down the road all the way to the bottom, that will give you -2. Okay? So the arteries are okay. What else we are looking at for cardiovascular profile? We look at the heart size. So if the heart is more than 1/3 or less than 1/3 or 1/3 or less. Okay? So this is the second thing. What else we look also at the function of the heart. Okay? So we look at the function. That will also give you 2 points, either minus or pluses. Do you?
No, it's fine.
Yeah. What else we are looking at? Ductus venosus? Yes. So the ductus venosus, actually there is a protocol. You can look in the paper. They call it Dr. Hota. I was trained partially for a short period of time by him. He's the one who developed this scoring system where we can say if the patient have 7+, then the patient should be okay and will survive. If the patient have 4 to 7, then the patient is really trouble, and less than 3 probably will die and will not make it. So it's very important for us. So what we saw there is, here you go, very nice, very nice. This is the Dr. Hota cardiovascular profile, and usually whenever I do a patient, especially if there is something wrong with it, I will also mention the cardiovascular profile, and I will add it as a point for, do you use this, Dr. Iram?
No, I only researched it for the conference.
Okay.
No, this, yeah.
The other thing, when you look at what we saw in the Doppler that Dr. Iram gave us, doesn't necessarily give us an idea about the rhythm. The best way to go to the rhythm is to go where? To the heart itself. Go to the house. Okay, so how can we get the rhythm? Dr. Diana, how do you help us?
So M mode, normally, if you can get a good view, or also you can try to scan both atrial and, systemic.
So atrium and ventricle both, and we put the M mode on them. However, be careful when you do a mode for the atrium, the atrial pulsation, you're not going to appreciate it really nice and crispy. Yes. So sometimes you have to imagine the contractility of the atrium. We cannot do an ECG, so all what we do is mechanic, okay? I only see the mechanic force, right? So I cannot see the actual, the actual ECG where I see the P wave. There is no such thing. His name is P wave. What other alternative that we can see the P wave for us to understand the rhythm? Yeah, so the PW of the inflow and outflow at once, both together. You can widen your scale to involve both of them.
Yeah.
Yes, aortic and mitral valve, because the other one, they are not neighbors. They hate each other. Tricuspid and pulmonary, they do not like each other. One, and it's just like my hand. Remember, this is my hand, the one I told you about. This is the tricuspid valve here, and this is the pulmonary valve right here. So you don't see each other, you don't talk to each other, you don't like each other. But the pulmonary, the mitral valve, and the aorta are very, very close. They hug each other around the clock. Okay. In the outflow in general,
So what is the risk of her progressing into a third-degree block?
Just to go for because we are, I think it's very good because I see there is one thing for sure our colleague in fetal medicine will refer, for sure, anytime there is any question about arrhythmias. And so one of them is the heart block. Heart block, if you suspect, let's say, patient with lupus, right, which they are susceptible for heart block. If they have the first child, then you should scan them in weekly basis starting at 16 weeks or sometimes earlier, and you should be very careful when you do the PW and from the mitral and aorta, and start to detect the possibility for developing the heart block. It will not develop third degree from first day. It will start first, second, and then third. So if you have any patient with lupus, you have to identify how much antibody they have. The more antibody they have, the more likely they will have a problem down the road. And if the woman have already a previous baby with heart block, already before the likely of the second baby to have a heart block, it almost reach about 50%. So it's a very scary if you don't treat them. Of course, we utilize some medication to decrease the inflammation, and most important, to treat the mom before even she gets pregnant. So you minimize the amount of antibody and the penetration to the conduction system. And of course, if I know the mom has a heart block, lupus, I will scan weekly, every week, one scan until they are about 24, 25 weeks. Usually after that, they don't develop a very bad block. So they usually stop at that time. And then after that, we just follow them every other 2 weeks. Yeah. Yeah, you know, we have to look at what you are, what's your protocol right now for patient with lupus? Okay. So you want to decrease the inflammation. So if you are not putting them in the steroid and you're not treating them, then you want to follow them. Okay? So when you follow them, that's when you decide, I want to treat or I don't want to treat. That's why I want, because steroid has its own side effect. I can't just throw steroid, take steroid and go on, and you have lupus and move on with your life. No, I have to make it sure that this patient is at danger for developing a heart block. And usually we'll also, even if we go through it, we follow the baby usually even after birth, even if they have a normal ECG immediately after birth, we still, because these antibodies, they stay for about maybe 3 to 6 months or whatever after birth. So we have to make it sure that this are done. Any other comment? Dr. Diana, how do you deal with them? Yeah. This is how I deal with them. I don't know if it's similar.
Yeah, the same. So we monitor every 2 weeks, yes, and sometimes what we do is we have in the middle, they go and have a fetal heart rate monitoring in between, and then we monitor until like around the same time, and then we continue to see them, but less often. And the treatment is the same, either beta blockers or steroids, and sometimes hydrochloroquine, depending on.
Okay.
Yeah.
All right. So anything else about heart block you would like to comment? How often you see them?
Yes, for if
not so common.
Yes, to try to decrease.
I don't know. I see. Well, I have a few patients who has
so when you
a pacemaker with a heart block. Yeah.
Antibodies are too high, and you're trying to prevent for the progression of the. Yes, it's shown that it helps.
Dr. Iram, you still have the rest? You sure? Yes. Are we done, guys?
It works.
We are done. So wait, don't go yet. Who is interested? Anyone interested to do hands-on training for?
Before in London. Yeah.
Okay. One. Yeah. Doctora, it's only 1,000 dirham. Come on. So نزلت الأيادي بسرعة بس قلت 1,000. حطها في جيبي هنا يعني. Don't come out. All right. Please, if you are interested, please send me as soon as today to my WhatsApp. Just send me, and then I will coordinate with Dr. Muzib and Dr. Iram. I think this will be one of the best things we ever done in fetal medicine in this country, because we really don't have any program whatsoever to try to train young people who see the patient every day. And this is a very nice skills to have. Very, very nice. For who? For who? For me? Okay. Dr. Nermeen, wait a minute, please. We will have to have a picture for all of us, so please don't go before you pay me the 1,000 dirham first. Yes. Dr. Muzib, this is for you.